Patient two's gait was somewhat unsteady, but he was able to walk unaided. Tandem gait was difficult to perform without missteps. Patient two's examination for spontaneous and gaze-evoked nystagmus. In primary gaze, you can observe spontaneous nystagmus. It is horizontal with the fast component towards the left. If you look carefully, there's also a rotational component to the left. When the patient is asked to look to the left, the nystagmus increases both in amplitude and frequency. When he looks to the right, it decreases. It's important to note that the direction of the nystagmus remains the same. That is, the direction of the horizontal nystagmus remains to the left no matter which direction he is looking. This woman has small abnormal beats of nystagmus, which when she is looking to the right, beats to the right. Then, when she looks to the left, the nystagmus changes direction and now beats to the left. This is called bidirectional nystagmus. Not every patient with a central cause to their vertigo has bidirectional nystagmus, but if it is seen, it is highly specific for central vertigo. To examine for test of vertical skew, the first demonstration is on a normal volunteer. Simply cover one eye with your hand, not touching the face, and after a few seconds, move it to cover the other eye. You are looking for any upward or diagonal movement of the eyes as they are uncovered. The examiner for patient 2 did not need to touch the patient's face, but in any case he had no vertical skew deviation. Here is an example of abnormal skew. When the right eye is uncovered, it moves diagonally upward and medially. When the left eye is uncovered, the eye moves diagonally downward and medially. This is an abnormal test of skew and indicates that the patient has a central cause for their vertigo and nystagmus. Note that purely horizontal movement does not count as abnormal skew. The head impulse test is the most useful part of the HINS Plus exam, but also the most challenging to perform and interpret correctly. So the technique will now be described in some detail. Have the patient look at your nose or at a camera held by an assistant. Of course, always ask for consent to video the patient. Videoing the head impulse test allows you to review the findings again and again and can increase your certainty of what you saw. I find filming it at normal speed more useful than it slowed down. Plus, it trains your eyes to pick up the fast catch-up saccade even when you aren't recording it. Hold the skull, not the jaw, firmly. An examiner can't injure a normal skull by holding it firmly, so don't be shy. If you don't sense the patient's skull under their scalp, you probably aren't holding it firmly enough. Start with a few slow movements to relax the patient's neck muscles, so when you move their head quickly, you won't cause any muscle strain or injury. Then start to perform the quick movements about 20 degrees from lateral to midline. Moving from lateral to midline is very unlikely to cause patient discomfort or injury. When you perform the head impulse test, activate your whole upper limb, not just your wrists. Get your biceps and pecs in there. You can move a patient's relaxed head from 20 degrees off center back to midline at high speed and you're not going to hurt them. If you move their head too slowly, you might not see the catch-up saccade very well. In a sort of random fashion, alternate the fast movement going from left 20 degrees off center to midline and then right 20 degrees off center to midline. Patient 2's head impulse test was abnormal when his head was turned briskly to the right. There is a catch-up saccade seen just there. There's no catch-up saccade when his head is turned to the left, although there's some nystagmus. The catch-up saccade is of larger amplitude than his nystagmus. There it is again. This woman, who demonstrated bidirectional nystagmus, has a normal head impulse test, which is concerning for a central cause to her vertigo and nystagmus. There is no catch-up saccade seen on testing either side. An abnormal head impulse test is seen in patients with vestibular neuritis, but rarely in patients with posterior circulation stroke. This explains the counterintuitive finding that a normal head impulse test is concerning for a central cause to her vertigo. To perform the bedside test of hearing, simply rub your fingers together a few inches away from the patient's ear on each side. Patient 2's bedside test of hearing was normal. So to summarize patient 2's HINTS Plus examination, he had a peripheral result for all 4 components of the HINTS Plus exam. His nystagmus was unidirectional to the left, his test of skew showed no vertical skew, his head impulse test was abnormal when his head was turned rapidly to the right, and he had no new hearing loss. Therefore, his overall HINTS Plus exam was peripheral. If he had had any of the following results, bidirectional nystagmus, abnormal skew, a normal head impulse test, or a new hearing loss, then his overall HINTS Plus exam would be a central result.